All right, let's continue to part 3 here. So let's talk about normal pancreas. It's an exocrine gland and an endocrine gland. The exocrine functions secrete sodium bicarb to neutralize the acidity of the stomach contents. These pancreatic juices contain enzymes for digesting carbs, fats, and proteins. The endocrine portion secretes glucagon to raise blood glucose levels. We have the islets of Langerhans that secrete insulin, and then insulin is secreted into the bloodstream, and of course is important for carb metabolism. So let's talk about pancreatitis. It's when the pancreas becomes inflamed. So you can have acute or chronic inflammation of the pancreas, which is associated with an escape of the pancreatic enzymes into surrounding tissues. Acute pancreatitis is a sudden inflammation of the pancreas caused by abnormal activation of digestive enzymes, like I said, which wreak havoc on the pancreas. When these digestive enzymes exert their effects on the pancreas, edema, inflammation, and vascular injury, and even cellular death can occur. Most common causes of acute pancreatitis are gallstones and alcohol abuse. Typically, acute pancreatitis is reversible. Acute pancreatitis occurs suddenly. There may be one attack, or they can have recurrent with resolutions in between. But a lot of times that can lead to chronic pancreatitis or chronic inflammation of the pancreas. This happens typically from multiple episodes of acute pancreatitis. It leads to irreversible damage to the pancreas. You may see some atrophy, fibrosis, and calcification of the pancreas due to this long-term inflammation. And it alters the function and the structure of the pancreas over time. In chronic pancreatitis, scar tissue ends up replacing pancreatic tissue. So precipitating factors include trauma, alcohol use, like I said, biliary tract disease, viral or bacterial disease, hyperlipidemia, hypercalcemia, cholelithiasis, hyperparathyroidism, ischemic vascular disease, and peptic ulcer disease. So with acute pancreatitis, so most common symptom you're going to see is abdominal pain. These patients are in a lot of pain. I've taken care of a lot of patients as a nurse in the hospital with acute pancreatitis, and these patients are in pain. I mean, they're just in pain. It is what it is. They're in a lot of pain, and we need to make sure we remember that. So abdominal pain may include a sudden onset at the mid-upper gastric or left upper quadrant location with radiation to the back. So this is more epigastric or left upper quadrant, whereas gallbladder is right upper quadrant. So the pain may be aggravated by a fatty meal, alcohol, or laying down. The patient most likely is going to have abdominal tenderness and guarding, nausea, vomiting, weight loss because they do not feel like eating, absent or decreased bowel sounds. In acute pancreatitis, you're going to see an elevated white blood cell count, elevated glucose, bilirubin, alk phos, and urinary amylase, elevated serum lipase and amylase level. Remember Cullen sign and Turner sign. Cullen sign is the discoloration of the abdomen in the periumbilical area. Turner sign is the bluest discoloration in the flanks. Both signs are indicative of pancreatitis. So let's talk about nursing interventions with acute pancreatitis. So like I said, pain management, that's all these patients care about. And they're in so much pain. I feel so sorry for them. So administered opiates as prescribed for pain. Typically, we're going to be withholding food and fluid orally during the acute period. They will be getting IV fluids if they're not obviously taking anything by mouth. Depending on how long the pain is and what the situation is, they may be on IV nutrition. We will need to administer any sort of supplements or vitamins as needed, depending on what the situation is. The patient may have an NG tube if the patient is vomiting or they have biliary tract obstruction or a paralytic ileus. They may prescribe a PPI or an H2 blocker to decrease the acid production and prevent activation of the pancreatic enzymes. A lot of times you're going to tell the patient to avoid alcohol. A lot of these patients are going to be admitted into the hospital, so they're not going to have access to alcohol, but it is important, especially with chronic disease, they want to avoid alcohol. If they have chronic pancreatitis, we do want to go over those acute signs. So the acute abdominal pain, jaundice, clay-colored stools, or dark urine. But most of the time, like I said, chronic pancreatitis develops from multiple episodes of acute pancreatitis. So most of the time, they're going to know these signs and symptoms to look out for. Okay, and then you guys had a discussion board on this, but let's talk about Gerd. So the esophagus is this collapsible muscular tube that's about 10 inches long. It carries food from the pharynx to the stomach. We have the stomach. There's hydrochloric acid in the stomach that kills microorganisms. It breaks down food into particles and provides this chemical environment that facilitates gastric enzyme activation. Pepsin is the chief coenzyme of gastric juices. Intrinsic factor comes from the parietal cells and is necessary for the absorption of vitamin B12. So that's just a little bit about the normal stomach and normal esophagus. So let's talk about gastroesophageal reflux disease. So GERD, or gastroesophageal reflux disease, you may hear the terms heartburn, acid reflux, GERD. These are often used interchangeably. And really, acid reflux could also be called gastroesophageal reflux. So like the stomach contents is backing up into the esophagus. And then GERD is the chronic or more severe version of acid reflux. So you can have acid reflux from, eating pizza and drinking beer or something like that. But GERD happens when it's more severe, and typically it's defined as when you have symptoms more than twice weekly. So it's this reflux of gastric or duodenal contents into the esophagus that results from an incompetent lower esophageal sphincter or incompetent LES. So the patient may have heartburn, obviously that can be used interchangeably, regurgitation, dysphagia, bad breath, chronic coughing. Those are some common symptoms you may see. A lot of patients are overweight. I often used to see a lot of patients come in after the holidays with symptoms of GERD or acid reflux. Really the number one cause and the number one fix for acid reflux is losing weight. And then when patients gain weight, a lot of acid reflux can happen. So some nursing interventions with acid reflux. We want to avoid factors that decrease the LES pressure or cause esophageal irritation. So things that can weaken that lower esophageal sphincter. Peppermint is a big one, coffee, chocolate, all the good stuff, right? Fried or fatty foods, carbonated beverages, alcohol, and cigarette smoking. These can all weaken the lower esophageal pressure, which then will increase the symptoms that they're having. So they're gonna need to work on their diet there. Instruct the client to eat low-fat, high-fiber diet. Avoid eating or drinking 2 hours before bedtime. That is very true because laying down is going to relax that LES. We want them to elevate the head of the bed 6 to 8 inches. They can buy these foam wedges that they can put under their pillow if the GERD is severe when they're lying down or the reflux is severe when they're lying down. Also, tight clothes can make acid reflux worse. Avoid certain foods. Avoid certain medications. NSAIDs, anticholinergics can help delay stomach emptying. Obviously, there's medications. There's a number of medications. I could give a whole lecture on the number of medications there are for acid reflux, but there's antacids, H2 blockers, proton pump inhibitors. There are so many different ones. PPIs are the most effective, proton pump inhibitors, but some of those are prescription. So they can get some of them over the counter, but a lot of times they've tried a lot of things before they come to see you. Surgery may be required in extreme cases, but it typically doesn't happen with GERD, very rarely. The procedure is a fundoplication, which is basically a wrapping of the portion of the gastric fundus around the sphincter or the area of the esophagus. It can be performed laparoscopically, more likely to happen if they have a hiatal hernia with GERD. And real quick, let's just talk about hiatal hernia. And this is the last thing we're going to talk about. This is a type of diaphragmatic hernia. Hiatal hernia happens when part of the stomach prolapses through the diaphragm. Many of the hiatal hernias are asymptomatic. They may be found on x-ray or endoscopy for another reason, but if symptoms do occur, the patient may have acid reflux symptoms, angina, dysphagia, or belching. Occurs more frequently in older women. Contributing factors: obesity, pregnancy, ascites, tumors, trauma, advanced stage, constant recumbent position, or heavy lifting. Obesity, though, plays a really big factor in the development of hiatal hernia. There's two types of hiatal hernias. We have a sliding hiatal hernia and a paraesophageal hiatal hernia, or a fixed hiatal hernia. Sliding hiatal hernia does just that. It slides back and forth from normal position to abnormal. Paraesophageal hernia results when the fundus and the greater curvature of the stomach rolls through the diaphragmatic defect and forms a pocket on the side of the esophagus. The paraesophageal hernia remains fixed, and this type is at risk for strangulation or incarceration. If the patient is symptomatic and needs treatment, depending on the severity, if there's no alarming symptoms, if they're just having symptoms, it's the same treatment that we do for acid reflux. So antacids, PPIs, H2 blockers, diet and lifestyle modification. But surgery, if obviously there's alarming symptoms, or there's a risk if it's strangulated or incarcerated, they need surgery, or if it's very severe, surgery is an option. But a lot of times patients have no symptoms at all. So I hope this was helpful, and I'll go ahead and post the other lecture about IBD. If you guys want to listen to it, you're more than welcome to. And I hope you're having a great week. Please reach out to me if you need anything. Have a great rest of your day. Take care.